Hi, everybody. I'm Kathy Lord, and welcome to the CART Distinguished Lecture Series. CART Distinguished Lecture is sponsored by the UCLA Tarjan Center, UCLA IDDRC, the CAN REACH Training Program, and the UCLA Brain Research Institute. It's my great pleasure today to introduce Dr. Carla Mazevsky, who's an associate professor of psychiatry and psychology at the University of Pittsburgh. We were teasing her this morning. She's from Pennsylvania, and maybe she's got 30,000 votes hidden under her basement. But we're very glad to have her, and she's survived as an expert in emotion regulation during this very interesting time. Dr. Mazevsky is a licensed clinical psychologist. She started her interest in psychology at William and Mary with an undergraduate degree with honors, went to Virginia Commonwealth University for a PhD in clinical, stayed on for a postdoc in clinical and genetics, also had an internship at Brown, and has been at Pittsburgh ever since. She started out in pediatrics and gradually shifted into psychiatry and psychology. And the reason why she's here is she is a rising star and internationally recognized expert in autism spectrum disorder, particularly related to emotion regulation, and also all the co-occurring mental health problems that go along with emotion regulation. Dr. Mazevsky has both created a new instrument, the Emotion Dysregulation Inventory, and worked on an intervention program. So she truly is coming at this from both the fronts of how do we recognize it and measure it, and what do we do about it. And she brings innovation and intelligence and clinical astuteness to a very, very important question. So Dr. Mazevsky, we're very glad to have you here and wish you were here in person, but maybe in the future.
Well, thank you for that lovely introduction. And I wish I was there in person too. I'm glad we can at least do it this way. I just wanted to start off with my disclosures of grant funding in this book that I'm excited we finally got published. So Kathy alluded to the fact that I started my, my undergraduate career at William & Mary. But I think it's kind of fun to think back to how did I even get so interested in this topic of emotion regulation and autism. And I had kind of an unusual path because I was fortunate enough in Williamsburg, Virginia, there's Eastern State Hospital, the oldest psychiatric hospital in the country. And they have a very unique not guilty by reason of insanity unit where I volunteered as an undergraduate and was fascinated. And I thought that I wanted to go into forensic psychology. I volunteered with the Williamsburg SWAT team and pretended to be like a hostage and started to get those kinds of experiences. And then I did my honors thesis on schizophrenia. But then I saw this sign, it looked almost exactly like this in the education building where I was taking one of my classes. And I was like, oh, I want to make a miracle. That sounds cool. So I called and they were looking for, it was a family that was looking for someone to work with their 9-year-old son with autism. So that was my first connection to autism. He was completely nonverbal. And so I became trained to be his ABA therapist. He had a lot of behaviors. So we spent a lot of time even just walking around the neighborhood because he would dart into traffic. This was pre-COVID. So he had an issue with, he would put his saliva in his hands and like rub it on my face. Mm-hmm. And the solution at that point was to assume that that was an attention-seeking behavior. So we were going to extinguish it and I would just ignore it and act like it wasn't happening. And lo and behold, it would go away, but it would come back with something else, sometimes worse, like fecal smearing or whatever it might be. So I always, ever since then, felt like we were really missing something with him, that there was some underlying distress, emotion dysregulation that we weren't capturing. And that has stuck with me. And I really, I guess, loved all the saliva and fecal smearing and became interested in this ever since. Then as things have gone along, I just have always been struck by the tremendous amount of psychiatric comorbidity in autism and all of the things that come with that, the distress for families, difficulty even completing treatments for other aspects of their autism, and then things from physical health problems, hospitalization, and whatnot. But I do have felt over the years, although I continue to focus in some part on mental health disorders and psychiatric comorbidity, there are so many challenges to that in autism, as I'm sure you all know, in terms of the diagnostic boundaries. It's really challenging to figure out when someone has an additional disorder, when it's part of their autism. Rarely do individuals have just one additional disorder. It's often more than one disorder. We already don't have enough providers who feel comfortable working with kids with autism or adults with autism. So the idea of like training people to learn how to treat all these different specific things plus autism just seems challenging. So I've really started to focus on what can we identify that cuts across these issues? Can we target that and make more bang for our buck, basically? So that has taken me to emotion dysregulation. So what I mean by emotion dysregulation is the idea of having intense, strong emotions that are difficult for the individual to change or modify to meet their goals. What I am not talking about is temper tantrums, which are normative behavior in young children. They're goal directed, which I think is a big difference. So we're talking about overwhelming responses to stress, difficulty downregulating negative emotion or upregulating positive emotion, but it's not the same as a temper tantrum. So what we've really tried to do in our research is develop new measurement tools. What I left off of here is better understand emotion dysregulation in autism, not just how it differs from the general population, but also what we can learn about variability within autism and emotion dysregulation, use all this information to develop treatments, and then we're working also on some technology-based support. So I'm going to highlight each of these areas today. So what I've spent quite a lot of time in my career on is developing the emotion dysregulation inventory. So I feel like I've talked about this a lot of times, so I'm going to try not to talk about it too much, but I'm proud of this measure for a lot of reasons. And one thing that we did that I feel like is important is we follow the PROMISE model, which is an NIH initiative for developing sensitive outcome measures. And one key part of that process is from the very beginning, we really made sure to partner with parents. This was developed originally as a parent report, to make sure that they are understanding the draft of the items in the way that we think they are. So we did cognitive interviews for all of the draft items where we basically asked the parents to talk aloud as they answer the item, give their thought process for how they're selecting different options, tell us what they think the item means in their own words, and then get feedback from them on if we're missing anything. And I really think this drastically helped us refine the measure. And then we collected 3 very large samples for psychometric analyses. We partnered with Ian for our sample that was intended to be representative of those with parent-reported professional diagnoses of autism. The autism inpatient collection we partnered with to have a sample that made sure that we weren't missing that very severe end of emotion dysregulation. I'm going to talk a little bit about this study at the end. I'm really proud of my work with this group. I love being part of this study. We have when we did this, we had 432 that contributed to the psychometric sample, but I just have to note, because I'm not going to mention this again later, that we now have 1,364 ADOS confirmed in patients with autism in this sample. It's just so exciting to me. And then we used 1,000 youth who are matched to the US Census on demographics as our general population sample. So the other thing we did is we really relied on item response theory analyses, which is the equivalent of the picture on the bottom right, and the picture on the top left is the equivalent of how measures are typically developed. So typically you kind of think of every response option as having equal weight. So like rating something as mild is the same difference, like mild over not at all is the same as moderate over mild. So basically you're just adding up the sum and that's your total score on a measure. Whereas in IRT, you can really look at the very like centimeters over the bar that you are. So you can look at how individual items inform the latent construct. You can weight different items differently. So having, for example, on the EDI, endorsing very severe on the item has explosive outbursts is going to impact your score going higher more so than if you were very severe for gets frustrated easily, because it's a higher threshold item. So I think all in all, it's really helped us increase the sensitivity and precision of the EDI. We did factor analyses, and this is the primary factor of the EDI. It's always hard to come up with a name. Reactivity, I really think it's reactivity and poor regulation. What it's really capturing is the initial intensity of emotion, being very fast, strong, and then difficulty down regulating that emotion. And these are example items from the short form. And then our secondary scale is dysphoria, I think equally important and often harder to detect. So this is more on the side of difficulty upregulating positive emotion and like kind of general unease and distress. The other thing that we did was differential item functioning to make sure every item performed the same psychometrically across individuals with and without intellectual disability, with and without fluent verbal ability, and now I'm blanking. We did that on a whole bunch of things. Age we looked at, and there was one more. But our goal was really to make sure that the EDI could be used across the spectrum. So we were excited by that. And then we were further excited to see that we can capture, this is a total information IRT curve, and we can capture variability from well below the mean to well above the mean at very high levels of reliability, and that we're capturing a lot of information even with just our 7-item scale in red. Then we did the psychometrics in the nationally representative sample, and I have to say I was a little surprised and amazed at how well it performed in that sample. And how similar the psychometrics looked as they did in autism, since really we developed it for autism to fill a gap. But we had the exact same factor structure, very sensitive, precise, valid. And the other key point about doing this step was that it provided us with general population expectations so we could set clinical cutoffs for screening. This is a similar picture with the US Census match sample. And even more so in this sample, it was really surprising to me how much the EDI captured more information across a wider range of severity than existing measures that are very widely used, such as like the affective reactivity index. And then in that sample, we also looked at how well it could predict things that we would expect to go along with high emotion dysregulation. And that turned out like this. So you see in all cases, those who've been hospitalized or have psychiatric diagnoses have much higher scores on the EDI than those who do not. So we're continuing to build on this work, and I developed an interest in measure development from this that we've continued on this path. So we're currently developing a young child version of the EDI. It's originally developed for 6 to 18-year-old, or well, really older. I really thought it could be used for older age ranges, but our initial grant reviewers didn't like our big age range. So we focused on validating it first in school age kids, but we are about to launch the psychometrics for the EDI young child and hope to have that available soon. And we're also linking that with the school-aged EDI to support longitudinal work. We're developing an EDI self-report for adolescents and adults. And when we do that, we'll get our adult norms, but I'm not changing the EDI for adults. It's going to be the same measure. And then the adult functioning scale is a new project that Kathy is actually on our expert panel for that, where we're developing a measure of adult functional outcomes for autism and other developmental disabilities. And then I'm working with Jen Fosfeg at Mount Sinai. She has a really interesting idea about increasing our precision in how we measure core autism symptoms by looking at their positive and negative valence. So we're now getting ready to launch the validation portion of that project and the psychometrics for her new measure. Okay, so that's a lot of effort in emotion regulation and measure development. Now my dog is walking in. Which we focus on because I really think it is something we can do something about. And I think it's something that families really care about and that really impacts life. And so I just thought I'd share a quote from a mother who emailed me. My husband and I describe him as being at once the most capable and most disabled person we know. His dysregulation manifests in severe emotional outbursts, both verbal and physical. However, when regulated, he's more rational, kind, and mature than his older neurotypical brothers. Emotion dysregulation is absolutely his chief obstacle to living a full life and having the chance to enjoy his many talents, and they are many. And this is a sort of story I feel like I hear all the time. So to put it a little more concretely, I'm borrowing a slide from my good collaborator and friend, Matt Siegel. If you think about how emotion dysregulation can further bend the developmental trajectory downward. So for example, say here is a 4-year-old in preschool who starts having behaviors, maybe some aggression, gets kicked out of preschool, spends 6 months without services, then gets into a specialized preschool. Other behaviors pop up. The family starts avoiding going to public places because the child is having more meltdowns, self-injurious behaviors, and their world just keeps shrinking. And then at this point, they're more socially isolated, having trouble even finding the right intensity level of services, wind up on multiple medications, hospitalized, and by here you see how much this has just brought them down from where they truly could be with their potential. So I feel like this is, again, another situation I see more often than I would like. This is not a smooth transition, but one other thing we've tried to do with the EDI is understand, like, so how often is emotion dysregulation really clinically elevated? Like, of course, we hear those stories of the kids where it's changing every aspect of their lives. And there have been a lot of studies, smaller studies, like some observational studies of young children, studies of more verbal, cognitively able adolescents and adults self-reporting on their emotion regulation strategies, but we still didn't really know, like, to what degree are kids with autism emotionally dysregulated compared to the general population. So we looked at the 3 samples that we used in our psychometric analyses, and I think what we found, these are rates of scoring above the EDI clinical cutoff, and what what you see with inpatient, I think makes sense. Almost all of them are above the clinical range for reactivity, almost 3/4 for dysphoria. But I think what's striking to me is in our community ASD sample, which is not a treatment seeking sample, they have 4 times the rate of clinically elevated youth in our ASD sample in the general youth sample for reactivity, and almost 2 times or more than 2 times for dysphoria. So that's a big number. Other things we found in our work are that higher emotion dysregulation on the EDI is related to more depression, anxiety, and aggression, more likely to be on psychiatric medications if your scores are higher, more likely to have had police contact, ER visits for behavioral crisis, in-home evaluations, more suicidal thoughts, especially associated with dysphoria, and then to have been hospitalized. And what I think is important about this is when we looked at these things, we really tried to account for other demographics, and we also tried to account for other aspects of self-regulation by looking at ADHD symptoms, and still you see pretty major role for emotion dysregulation in all of these things cross-sectionally. I would love to look at it longitudinally. So one thing that I think is important to remember in all of this is a slide that I used to show when I would do talks like in graduate school or after, where I try and capture like the variability in what we see in emotion in kids with autism, where you really do see a bunch of kids who are just kind of happy-go-lucky, like nothing seems to faze them. There's a dog barking. Sorry. And then other kids who are really nervous and anxious. Other kids who are kind of consistently irritable or angry. And then those who are usually okay, go along doing fine most of the time, but then have like explosive outbursts or meltdowns. So I think that's important to remember. And also with those rates that I showed before, that it's not all kids, but it's a sizable number of kids. And we do need to consider within ASD what's driving those differences. So luckily I have a super smart postdoc named Jessie Northrup, who's married to a statistician, which is convenient. And they're helping me look at this other data with the EDI that we collected when we developed it, where we had all of the items rated on the severity scale. And then we also had every item rated on this other scale, which really was trying to capture how does like the current behavior compare to the emotion dysregulation over the course of their lifetime, to get a little bit of a better sense of stability. So this is some of the preliminary findings of this work. We're changing how we're gonna look at these analyses a little bit, but I still think I can give you the sense of things. So basically what we're seeing here in the general US sample, you see pretty much, low, average, what you'd expect, reactivity, severity, and stability. It's pretty stable. Whereas in the inpatient sample, as you'd expect, their severity is higher, and then they also are less stable. And then in the community ASD group, you just see this huge range across both severity and stability, where those things are both moving around a lot. So, I mean, there's a lot of variability within autism here. So another part of this is following up on that ASD sample, the community ASD sample, and looking at predictors of emotion dysregulation, severity, and stability. So I'm just going to highlight a couple of the findings I found most interesting. So one thing we found is that stereotype behavior is a consistent predictor of both reactivity and dysphoria severity and stability. And that's in line with something previously reported by Andrea Sampson, where she found repetitive and restricted behaviors to be the strongest link between ASD symptoms and emotion regulation. Also, kind of surprising, I don't know that we would have predicted it, but really intriguing to me, we found that the relationship between reactivity and dysphoria seems to differ in ASD and the general population sample. In the general population sample, we pretty much see as reactivity goes up, dysphoria goes up, and that's not the case in autism. So at like stable levels of reactivity, dysphoria is actually lower in autism than it is in the general population. And then we see some really interesting age effects. This is maybe not that surprising, that reactivity is lower among older kids. So this is an age range of 6 to 17. And yet dysphoria is higher in older kids. I think both those you'd expect based on the general population literature. But we looked at these sort of optimal combined moderator models using a machine learning type of analysis approach, where you looked at every possible combination of moderators to see if things interact. And what we find here is that basically the effect of improving reactivity with age is stronger among those without moderate to severe intellectual disability. So you don't see that decreasing reactivity as much in those with moderate to severe intellectual disability. And then also, that should say effect, not effective. The effect of increasing, and that should say dysphoria. I threw this in this morning, so ignore those typos. So I'll just explain it. Basically, the effect of dysphoria increasing with age is stronger for those with fluent speech. So I think these are kind of important lessons to learn about how all these different aspects of functioning may interact with patterns across development. Again, with the caveat, this is cross-sectional, and it's a very exploratory machine learning kind of analysis. The other final finding I'm going to talk about with this, I think is really interesting. So looking at interactions between gender and intellectual disability status. So basically what you see is for those with either mild intellectual disability or average or better cognitive functioning, both genders are kind of equivalent in their reactivity. But for those females with moderate to severe intellectual disability, they have much higher reactivity. So there might be something about that combination of being female and more profoundly affected by their intellectual disability that increases risk potentially for emotional dysregulation as well. So I feel like we're learning a lot, and just like to reflect on, where the field has come. It's not just our work. Other people are focusing on emotion dysregulation and at a very steady and rapidly increasing pace. When we wrote this review paper, or it wasn't really a review because there were only 15 papers. When we wrote this paper about the role of emotion regulation in autism in 2012, there were literally only 15 papers with both emotion regulation and autism in the abstract. And I did this, I reran this 2 days ago, and it was up to 195. So that's a very exciting increase to see. And then another thing I think that's even more exciting to think about is that doesn't capture all of the ongoing work. So this is just a slide of where the EDI is being used. All these people are looking at emotion dysregulation. It's being used more and more also outside of autism, but this is definitely majority autism. So I wanted to highlight a couple of really what I thought are some of the more exciting ways that we're seeing the EDI being used. And one that I think is really important clinically is that we're seeing it being requested more and more for universal screening. We're doing that here in our outpatient clinic for autism. Also, at your nearby neighbor, UCSF, they're doing that. And then in the Netherlands, and then some interesting places. This is just one example where they're using it in a welfare program in New Zealand for that. And then also, I'm excited to see uses for progress monitoring. So one of the things we did do, I didn't mention earlier, was to establish change sensitivity of the EDI so that it could be used in clinical trials and in the context of clinical programs. So here are just a couple of examples of ways it's being used for that. Got an RTMS study looking at how emotion dysregulations impact neural synchrony between the parent and child during social tasks, and then looking at other kinds of interventions like therapeutic horseback riding. So all kind of exciting things. I can't wait to hear what we learn. Now to shift to more positive part of my talk, I think one of the good things is we do see change in emotion regulation with treatment. This is just a clinical anecdote from a mother who emailed me. After 9 months of intensive sessions twice a week, results nothing short of miraculous. This after trying every type of therapy and medication out there. Without addressing her emotion regulation issues, nothing else was possible. I think there's a lot of potential to treat emotion regulation in autism, yet there's still a huge shortage of providers and not a lot of evidence-based treatments out there yet. But I'm excited that we know enough now that we can at least start to talk about how we might go about this clinically. So this is just an example of a paper we recently published, almost geared more for the non-ASD specialist than the ASD specialist, but trying to give some pointers. Say, if you know how to treat emotion dysregulation outside of autism, at least give it a try when you see a patient who comes to your door with autism, because sometimes they do get turned away, which is sad. So even from like the cognitive behavioral therapy literature, we've learned a lot about how we can modify therapies for autism. So we try and summarize some of that in that paper. Also, we're beginning to see more and more emotion regulation interventions being developed and tested explicitly for autism. Like the STAMP program for young children, more of a CBT program, the Secret Agent Society, Regulating Together, which is an intensive outpatient treatment program, mindfulness-based, and then our program is called EASE. The one thing I do want to point out, I underline emerging, because there are no published randomized controlled trials with a comparison treatment. We have one underway. Okay, so I'm just going to tell you a little bit about what our program is like. So it's called EASE, and the idea with EASE is we were trying to see if we can improve emotion regulation with that as our target. Can we decrease psychiatric symptoms, problem behaviors, and functional impairment? So we spent a lot of time developing EASE. First, we wrote the manual based on our clinical experiences, pulling from some mindfulness-based and CBT literature, and then trying to rely on the research on emotion regulation and autism in particular. We had the manual reviewed by adults with autism, by parents of children with autism, and by therapists who work with individuals with autism, and revised it again. We developed an online adjunct, which we called Emotion Coach or eCoach. And then we ran a pilot study, just an open trial with 20 adolescents with autism at Virginia Tech and Pitt. And then we revised the manual again. And then we're currently running a 2-site randomized controlled trial at the University of Alabama and Pittsburgh, comparing EASE to individualized supportive therapy. And we recently modified it for individuals with ASD and co-occurring intellectual disability who may not be fluently verbal. And we're calling that we're calling that Team Ease or Ease Team. And we're basically doing all these steps all over again. So one of the key points that we try and emphasize in ease is that emotions are natural and normal. We're not trying to get rid of emotions. We're just trying to stay in control in the face of strong negative emotions. So this is a picture of that concept from one of our participants who did this amazing, like, illustrated little series of things for us when she finished the program about what she learned. But just to give this a more concrete example of this concept. So before this talk, I came home to find my children did not shut the pantry door. So my puppy had eaten all kinds of things that could make him very sick. I'm very annoyed at my children, and I'm very worried about my puppy throwing up. But those are, normal emotions for me to be feeling in that circumstance, yet I still have this talk to do. And my goal is to have it be the best distinguished lecture ever. So I'm staying in control in the face of all of those emotions. So that's really what we're trying to teach them to do. And I think it's really important in our population to, they run into so many negative things in their lives, or kids being horrible to them. And of course, they're going to feel angry, just like anyone would. This is something we really emphasize. The other thing we really tried to do is to make it easy to digest. So sometimes some of the great interventions out there, I think, have like complicated acronyms or all of these steps that in reality are hard to apply in the moment. So we have a simple A, B, C, D model. And the other thing that we really try and do, is highlighted by those boxes in blue, is after we teach any major new skill, we have a community session, and that is sometimes literally going into the community to practice something. But basically the idea is to try and bring more of the real life into the therapeutic relationship, because obviously we all know that generalization can be a challenge, and it's a lot easier when you're like in a nice empathic situation with a skilled therapist. But the stressors that they encounter in daily life can be a lot more challenging. So we try as much as possible to elicit emotion dysregulation in the therapy through these community sessions, so we have a chance to really practice the skills and hopefully solidify the learning and improve generalization. That should say Ease Team, since we kind of changed the name. The reason we changed the name is because a lot of what we've learned doing Ease Team is stuff that I think would help for also individuals with ASD without ID. So I think it's not as easy of an align of who might prefer which sort of approach to the treatment. Basically, this is an example. Took some of the concepts from EASE and made them more appropriate for a population with cognitive delays or less language ability. And basically, we have two mindfulness practices on the top: walking and breathing. And we really increase a lot of repetition. We have visuals, and we just have like these 4 skills. And I'm going to talk a little bit more about other things that we did with it. A key component of both is our focus on awareness. So we have this sort of hierarchy where awareness is the main thing, and we spend almost half of the treatment focusing on increasing awareness of emotions. And what we really focus on is increasing awareness of the intensity of the emotion and how that changes. And I really don't care if they can say if they're mad versus sad versus nervous. Like, we're not working on emotion vocabulary or differentiating emotions. We focus on the severity of, or the degree of emotion arousal, because really feel like it's hard to do anything with regulating your emotions if you don't notice it until you're exploding. So like the goal is to really begin to notice changes in emotion earlier so that you can do some of the skills to regulate. I should have said this earlier, but we primarily think of it as a mindfulness-based intervention. So really feel strongly that mindfulness might help here. It's very hard to define mindfulness. I think it differs for everybody in their experience. But a commonly used definition is paying attention to the present moment, sensations, thoughts, and emotions without judgment. We think this makes a lot of sense because of our goal to increase awareness. So that, inner focus really helps with building that awareness. And that is the primary way we really work on those awareness skills. Also, the research on emotion regulation strategies in autism has really shown that a tendency to rely on escaping and suppressing emotion. So I think that our idea is that if they can slow down their emotional reactions, that'll give them a chance to also reduce this tendency to escape and suppress. So in doing this, I think it can be done, and it can be done well, and we see a lot of great response to mindfulness in our trial. We also have encountered some challenges. So we tried to, I always hate that we're in the middle of this trial, so we can't just give the manual out or disseminate it quite yet. But so we're trying to share the information we're learning along the way as much as we can. And this paper is one way we tried to do that with our mindfulness challenges. So we do see common things come up that are hard for the client. And then we also see some common things that are hard for the clinician. So we go over those in this paper. And we also kind of, we have made some adaptations from more traditional MBI, mindfulness-based interventions in our program, like reducing metaphors, allowing for more space and silence in between the talking, and that sometimes feels counterintuitive, especially when a lot of our clients might have high inattention or hyperactivity, but we find it's actually helpful to give them a chance to let their mind wander and practice redirecting their attention back inward. And using permissive language we find is really important. So instead of saying, being more directive, being like, now you may, lots of ing words. That's pretty consistent with the usual at MBI actually, but we really try and focus on that. I'm gonna give an example of using props. Let's see. Yeah, and we started, one of the major changes between our open trial and our randomized trial versions of EASE is we really reduced the number of meditations we were using. Less is more in this way, I think, because then we can focus on fewer with a lot of repetition, and we find that that's really helpful. So this is just an example of what we commonly see. What did you notice in that meditation? I don't know. Did you notice anything in your body? Calm. Great. Where did you notice that in your body? I don't know. Did you notice your breathing? Nothing. Emotions, nothing. And that's fine. So I think, first of all, that's what we expect. We know that awareness of emotions can be tough for a lot of people with autism. Other thing that I think this example brings up is I think this can be hard for clinicians in this situation, but the idea with EASE and with most MBIs is that there is no right or wrong way to do it, and to really be accepting and not non-judgmental. So I think in some ways, if you go on asking too many questions looking for a response, you're kind of giving the feeling to the client that there's something they're supposed to be saying, but it's okay if they're not noticing anything initially. The bottom picture here is an example of a client who kind of struggled with this, but she was a teenage girl who was really into Pikachu, and she would carry it with her often. So we started with first noticing how Pikachu feels in your hands, then being able to notice the sounds of the vent in the room, and then finally was able to get better at noticing her internal sensations. Just going to check my time. Okay. So after the meditations, there's always usually an inquiry about what did you notice during that mindfulness practice. So we find that one easy pitfall is too much explaining about what it should be like, or things like that, and that goes counter to the idea of accepting, or basically it gives the idea that there's something that they should be doing. And then too many questions, the same thing. So what we really try and do instead, and we've really embraced this, especially in team ease, is a lot of modeling. So I might say, I felt that I noticed my breathing most in my stomach, if they're not giving us anything. The other thing that we've done in terms of props for Ease ID, we have our team ease. We've used the Hoberman ball, which is in the top left, where you can expand and close that with your breathing. And we use a lot of like, put your hand on your chest and your belly. I love this team approach that we've been using in Ease Team. We really partner with parents and caregivers in this treatment. We still give space for our young adults, especially to have one-on-one time with the therapist, even if they're not fully verbal. I find that to be actually pretty essential, but we also find it to be essential to get help from the caregivers. And this was one of the things where COVID was a blessing in disguise, for one thing at least, because we were partway into this open trial and COVID hit and we had to stop. So we basically rewrote the whole manual based on what we had learned with our first 5 clients, and really ramped up this team and supported her. So in good model, I know that I'm getting whatever their word is for emotionally distressed. I'm going to stop and breathe. That could be the parent saying that anytime that they have an opportunity where they might be feeling some emotion, and then doing things together. So I see you are upset, let's breathe together. So this is very different from telling someone to calm down, which is almost impossible for anyone to do when they're upset. I mean, I've had people say to me, if I could calm down, I would. And that really tends to escalate people, but it's really natural and easy to do in the situation. So just reminding to do things together, and having someone like yell at you, you just need to breathe, also kind of backfires. So again, really different from the team approach of doing things. Also, I think there's this tendency to try and like encourage the emotional understanding in the moment, like how are you feeling, what's wrong? But we know that that emotional identification can be tough. So it's better to say, I see you are upset, and help them learn that, and then trying to process in the moment of escalation. The other thing we focus on a lot is, and I'm not covering every aspect of the treatment, I just want to focus on a couple of things, is we really use sensation-focused distraction. So kind of as a temporary tool, because we don't want avoidance to happen, but intentionally shifting their focus to a sensation. So in regular ease, we teach that first with the soles of your feet exercise, which is kind of a cool one, where you think about something distressing and you're really sitting with that, you're trying to get yourself worked up and like, really thinking about it. And then you try and shift all of your attention to the soles of your feet, which is hard to do, but the more and more you practice, that gets you to really focus on how to do that in moments of distress, where you can focus on something, a different sensation to keep yourself in check. In Ease ID, team, I keep doing that, Ease team, we give all these kinds of different options, and this is the same, like the idea is really just to use any kind of sensation for that temporary distraction, and it's something they generally take to naturally, I would say. And I think my videos aren't working great. I was going to show this clip, and it's basically just him. This is a young adult male in our program who I'm seeing, who is really tough. His nonverbal IQ is about 73, expressive language level about 7, although I've really only heard him say, like, 7 years old. I've really only heard him say a couple of words, but his most favorite words are stop talking and be quiet, which was how our first 3 sessions, I think, went mostly, was him telling me to stop talking. So I listened. I stopped talking. I try and reduce the language. That's something I think we really do in Ease ID. But for him, and I think we see this as if you're emotionally dysregulated your whole life, by the time you get to be a big adult, and people see a sign of something, it's very natural to back off and remove all demands. So in his case, he's learned to say, stop talking, and he kind of is able to get out of what he didn't want to do. So this is just a nice example of, after weeks of, slowly building these skills, he's really allowing me to push him, and he's trying with the distraction. He liked the squeezing brain. He's able to listen to me walking him through it. I still don't get anything from him in the inquiry. Anything he's telling me he's noticing in his body, and I think that's totally fine. I can see he's doing it. I can see a huge improvement in him following along. He has an amazing mother who practices with him like multiple times a day. So that's the kind of thing we're going for. Okay, let's see if I think I'm going to skip over these because these are just some other examples of kids. So we have our pilot child data was very exciting. That's already been published, but now we're doing this more stringent RCT. I just want to end with a couple of other things that we have going on. So this is kind of a complicated slide, so don't worry about it too much. But basically, what we're doing is partnering with Murat Akaya, who's my collaborator in our engineering department, and we're doing EEG pre and post Ease. And right now we're at this stage where we're looking at the EEG data to classify brain activity in response to frustration as just that goes along with distress and non-distress. And our goal is to eventually develop a virtual reality platform to practice the Ease strategies, where we could cue them, so we could create situations that are more realistic for them and distressing potentially, and then cue them to use the Ease strategies based on their neural activity. Along the same lines of the using technology, my partners with my Matt and Matt here for the autism inpatient collection. We've had this hypothesis that the aggression that we see is an attempt to modulate their internal arousal. So we have some pretty exciting pilot data on using physiological arousal data to predict the onset of aggression before it occurs. That was published based on 20 minimally verbal youth. So basically what we're doing is we're working with kids who are hospitalized on specialized inpatient units, and they're wearing a wrist-worn biosensor while a research assistant is coding their behavior as an onset and offset of aggression, self-injury, or emotion dysregulation. They're not sitting at a desk because it's an inpatient unit, they're usually walking around or doing something. But we're collecting 4 to 10 hours per patient. That's just what we're coding. And the idea is we're using machine learning to identify patterns in the physiological arousal data that precede the aggression. And we're now at 98% accuracy, 3 minutes prior, at predicting the onset of aggression. So starting in January, we're hoping to do a proof of concept where we give an alert to the direct care staff that something is coming, basically, and hope to see that even without any extra intervention, that we hope that that can reduce exclusion, restraint, staff injuries, and the rates of aggression. So that's ongoing work that we're super excited about. And then my goal would be if we could then incorporate that also into EASE to help with self-monitoring. So merging the two studies together. Okay, I think I used up my full hour, so I just want to thank all of my amazing collaborators, mentees, staff, everybody who helped this possible, and the families. And then just in case there's trainees, this is too tiny to see, but I don't want anyone to forget that we have amazing clinical programs. Also, I don't think we have a good way of advertising it because of our website, which I've been working on for years with our UPMC, University of Pittsburgh Medical Center. But this entire list is all autism programs. We have everything from intensive inpatient programs for children through adults to all kinds of early childhood programs, amazing breadth of services. So I just encourage you to consider looking at Western Psych if you are a medical or psychology or any kind of trainee or interested in research as well. So I will end on that. Oh, you're muted, Kathy.
Let's see. Yes, I can. I got a note saying earlier, you are muted. So thank you very much, Dr. Masevsky, for a wonderful talk about a whole range of questions. And just as I start talking, our garbage cans, our garbage men are coming down the street. But let me first, I won't jump in with my own questions, but I'll start with questions people have asked. So
Okay.
One of the first questions was with regard to your comment earlier about not temper tantrums. So how do you tell the difference between a strong emotional outburst and a goal-oriented temper tantrum? And where would you, I think, draw the line?
Yeah. And I mean, I don't think we have a good way of distinguishing them, to be honest. I mean, unless we're going to do like a functional behavior assessment like every time. I think it's probably easier to tell when it's just a temper tantrum, when there's a clear like goal in mind, where like, so for example, like a kid who wants to eat more Halloween candy on Halloween and their mom says no, and they like throw themselves on the ground and are like screaming. I think it's just that like idea of things is not what I'm talking about. Just more the idea of like, I think it goes along with each other because it can evolve into more emotion dysregulation if that kid can't pull it together for like 10 minutes, then clearly that's emotion dysregulation now. They're not able to calm back down. But I think it's the idea of interfering with goals versus for a goal, if that makes sense.
So it sounds like, I mean, I was thinking that one of the strengths of your approach is we all have moments of emotion regulation, dysregulation.
Yeah.
So it is a universal phenomenon, but sometimes it interferes and sometimes it doesn't. I mean, and that's probably true minute to minute, but also there's people where it interferes more often.
Right.
The next question was about using the EDI, and I think this was a question before you had actually showed some of the projects that are using it. But one of the listeners asked, how is it different from other socio-emotional measures like the BASC? Does it fit into sort of ideas of special ed eligibility, diagnosis? And then you'd also referred to it as measuring progress. So that's a complicated question, sorry, but.
Yeah, it's very different from the BASC because the BASC is, well, it's more specific than the BASC. So it's just emotion dysregulation, whereas the BASC covers a range of things. Yeah, so let's see. Yeah, so I might be losing the point of the question.
I think this person was interested in partly, it sounds like, getting like clinical diagnosis, special ed eligibility.
Okay. Yeah.
And then measuring progress seems like a separate issue.
Yeah, so I mean, I don't know if it's been used for eligibility purposes yet, I mean, so it's not tied to a diagnosis. I mean, I think that's one key point. It's measuring process, or like, could be related to, it's not like a measure of a specific disorder. It's emotion dysregulation, which can be across disorders. Certainly related to the need for treatment, though, I think, when it's too high. So I do think it can be used for screening purposes to determine whether services are needed. I mean, people are definitely using it in that way. People are using it within clinical services to monitor change, inpatient and outpatient, or in clinical trials. But I don't know about, I wouldn't necessarily say it maps like one-on-one to like whether or not a child has a diagnosis. It wasn't really designed to do that. If that makes sense. Or yeah, in eligibility, I might depend on how a program defines like what meets eligibility for their services. I mean, I would love that not to be tied to having an additional diagnosis, because I don't think it should be, but that's the case for a lot of programs.
Yeah, I mean, I would agree. I mean, we've really tried, even with the ADAS CSS, to get people to say you can use this even if you don't reach a diagnosis. Yeah. And the EDI is even better in terms of describing a difficulty that can definitely impact behavior, even if it doesn't fit in just one diagnosis. I was thinking actually just a pitch for the EDI, Carla, is that one of the things we found in our longitudinal study of autistic kids from 2 to age 30 is we can't predict emotional difficulties at 30, which are major problems. So we can't predict mental health at 30, even though we can do quite a good job of predicting objective things like, are they working? Do they have a place to live? IQ predicts enormous amounts of things. So does autism, but not whether they're depressed, severely anxious, having behavioral difficulties. And if we'd had the EDI at 2, who knows what we could do?
Oh, I wish we had.
Because I think we just didn't measure the right things. It's not that, I mean, I don't know if you can predict them, but we didn't. And you are trying to do that, I think, in part. The other thing, and maybe that this person asked, is just measuring progress. You'd said that you have looked at it as a way of potentially measuring progress. Is that right?
Definitely. Yeah, that's definitely accurate. And like for example, at the neurobehavioral unit at Kennedy Krieger, they do it weekly, and they map it on to changes in their behavioral and medication treatments, or other people just in like general practice. Because, we know that treatments don't work. The same treatment doesn't work for every kid. So it would be good to make sure what we're doing is working.
Changes. Well, good. It's good if you can see change.
Yeah.
We have another question regarding females with moderate to severe ID having higher reactivity. Do you have information about the rates of epilepsy in this sample? The females with ASD and moderate to severe ID do tend to have more epilepsy. I wonder if that could have an impact on emotion regulation, both the seizures themselves, medication, and brain function.
Well, that is a super interesting question. I have not looked at that, but we do have that data. So I will have to check that out. Yeah, that's a great thought.
Another question is, you mentioned that stereotypic behavior is associated with emotion dysregulation. Did you look at the relationship between inflexibility, rigidity, and dysregulation as well?
We didn't have a specific measure of that in this study. I think that would be very important to do.
Another comment from Liz Laugesen, interesting and important research. Are you offering ease over telehealth, and are you recruiting across the US? You want some more people?
Yeah, so, I resisted going to telehealth initially because I think I just felt like there's so much you might lose in the, interaction. But when COVID went on for so long, continues to go on, we did shift to telehealth entirely for a period of time. And now we're back in person. Our research started up back in person a couple months ago. And we decided to retain the telehealth option. So some people are choosing telehealth and some people are choosing in person. And then the issue of across state lines has been a tricky one. Like, can you do that? Can you not do that? It's research. It's not a billable clinical service. So the latest I heard was we can do it. For a while, I was told I can't do it. So we are becoming more relaxed about that. Ideally, we do have the EEG, so we've taken more like local people, like from Ohio, and they come in and do an EEG if they're comfortable with the COVID procedures. But that's also an optional part of the study. So
well, let us know.
That's kind of a really wishy-washy answer. So maybe.
Let us know if you need cases from California.
Yeah, I will.
So another question is, thanks for sharing your work. The talk was very engaging. You mentioned that RRBs were a consistent predictor of reactivity, dysphoria, severity, and stability. Could you talk more about the direction of change in terms of EDI scores if RRBs become more severe? And do you have a sense of how that links to consequences such as hospitalization, crises, arrests?
I don't know if I have a sense for the last part of how it links to hospitalization, crises, etc., other than like our other paper that didn't look at that. I mean, finds a clear link between reactivity and those outcomes cross-sectionally.
I think somebody's asking, I think they might be asking if RRBs become more severe, do EDI scores also increase, and does that lead to more, problematic consequences?
Yeah. So the way we define stability, because it was really tricky to pull that data together because every stability rating is tied to a specific severity rating for that item. So in the end, what we decided to do was lump together better and worse as like changing. So it is a little hard to know the direction of that finding. Although we can look at that, and we haven't submitted this yet, so we can do that as like a post hoc analysis. I would suspect that it's more often increasing with worsening. But just basically, I think what we can say is that it's increasing reactivity. Changing reactivity and increasing reactivity is more associated with higher RRB, but I can't really say it's the specific direction that question is getting at.
Okay. What age range is the EDI standardized for?
I would say 6 and up, because I do think the version we're developing for young children will be better for 2 to 5-year-olds. So I would just say to be cautious using it under 6. Our normative data is up through 17. We have some up through 20. We do use it in our own work in adults, and other people are using it in adults. I think the items work just fine with adults, but we don't have the adult norms, if that makes sense.
And is the EASE manual available for therapists in private practice?
Um, we're not sharing the EASE manual yet, just because we're in the third of the fourth year of the 4-year trial. But we have put together as materials to hopefully help clinicians who want to try similar things. So we do have like a 4-page kind of handout about
Mhm.
strategies, and we've written a couple of clinically oriented papers to try and share some of what we've learned. So I'm always happy to share that kind of information.
Thanks. Since earlier diagnosis of autism is occurring, do you think parental training, teaching parents and their child about emotion regulation earlier may avoid later problems?
Yes. Yeah. So, yeah. So I've always focused mostly, I just have loved working with adolescents. The transition to adulthood, adults has been probably the focus of my work primarily, but I'm lucky to have two postdocs who are interested in early childhood, Taylor Day and Jesse Northrup, and Jesse in particular is interested in parent-child interactions and how that impacts development. So this is something we've talked about a lot, and I'm really excited about the EDI young child
Mhm.
because I think we have to get in there sooner. I think our early, our early intervention programs could focus even more on emotion regulation, and I definitely think it would be essential to partner with parents. And I like the idea of also working with parents on their own emotion regulation.
Yeah.
Yeah.
Um, this one said, I noticed that once the young adult graduates from high school, there are no routine activities anymore. And while parents are working, it creates a stressful situation for the individual with autism. Do you notice the same? Any ideas that you care to share about particular issues related to young adults and not having things to do?
I definitely see that problem all the time. Yeah, and it seems to be even worse for those who do not have intellectual disability because they don't tend to have fewer services and daytime activities. Do I have a solution for that? I wish. I think we need more services, and ideally we would partner, earlier before the services drop off to come up with some plans and get people on the right track to connect to other things that they could do meaningfully with their day. I am working with Susan White at University of Alabama. She has a program called the STEPPed Transition in Education program. I'm gonna butcher the acronym. STEPS is what it's called, and we just submitted a big grant. Fingers crossed, it would be like a 3-site effectiveness implementation study of STEPS, working with community agencies, with the idea being the clinicians would work with the adolescents and young adults on their, basically to improve that transition to adulthood, hopefully giving them the skills to even, seek out some more meaningful daytime activities. Because I do think it contributes to emotion dysregulation also and outcomes, obviously.
It is great you're doing that.
Yeah.
Someone asked specifically about kids that are moving around, like in military families or for whatever reason, and how that might both provide an environment that promotes acceptance and open-mindedness because people are moving in and out, but also interventions may be inconsistent. Is there a role for EDI in that? I guess the question would be if you could teach, if everyone knew EDI, if everyone knew
Yeah.
EASE, then it could go on across different places.
Yeah. Well, one of the reasons I've been so excited about the use of ease, like picking up so much, is like I feel like, with all autism research, every paper says something like totally different. So it would be nice to have some measures that we're using consistently to start to get a sense of what's actually going on.
Yeah.
And, But yeah, so I mean, it also is just, it's rated on the past 7 days, so it could even be used to maybe try and understand, patterns with the
Yeah.
child's behavior in those situations. But I agree, you could see that kind of situation both helping and hurting.
And
Might depend on
actually,
the kids. Yeah.
sorry, following up on that question, somebody asked, how often can you administer the EDI? Are there any issues with repeated administration?
No issues. We really followed the promise model, and we wanted it to be able to be repeated and used for measuring change and progress. So that's why we wound up with a 7-day time frame. So it just asked about the last week, which has been kind of interesting because I mean, you do see a lot of variability week to week in kids with autism in their emotion dysregulation. I just think that's been interesting kind of observation in our clinical trial, but you can certainly repeat it.
Yeah.
Um,
There's a question about, there appears to be a discussion of the adaptedness or functionality of emotion regulation strategies. How would you distinguish between a functional adaptive regulation strategy and a non-functional, non-adaptive regulation strategy? And is that distinction related to the ability to return to a goal-oriented task?
So it's mostly not been conceptualized as the ability to return to a goal-oriented task, although I think that would make a lot of sense to measure it in that way. That distinction is mostly coming from the literature tying different strategies to psychopathology.
Mhm.
So mostly from like the general emotion regulation literature, where you see cognitive reappraisal, for example, is considered adaptive because people who use it are less likely to have anxiety and depression, whereas people who ruminate, that's considered a maladaptive emotion regulation strategy because it's highly tied to higher rates of depression and anxiety. So it's more of that thing. However, nothing is universally adaptive or maladaptive. So it's kind of this gross categorization because like anything in life, too much of something is sometimes bad. So it's also the ability to use things flexibly. And there's been really interesting literature. I think I just am finishing this review paper, a systematic review of the psychometrics of emotion regulation measures that are out there, generally not autism specific. And one interesting thing reading about their validation is you do see there seems like there's a much stronger relationship between maladaptive strategies and psychopathology than there is with adaptive behaviors. I mean, adaptive emotion regulation strategies. So sometimes those maladaptive ones kind of take over.
Yeah.
Even if there's,
It makes sense, but it's interesting given that often, we've thought, I mean, if you think about like schizophrenia and the negative symptoms are probably more predictive than the positive symptoms, but here when you're doing something overtly maladaptive, that is worse than doing something adaptive, maybe. I don't know. It's interesting. How does anxiety fit into it? I mean, I feel like we see so many families who say, my child does this because he's anxious, and we've got to decrease the anxiety before anything before anything else can happen. Whereas it feels like what you're doing is addressing many of the things that families would describe as anxious, but are actually also dealing emotion regulation.
Yeah, I mean, I think, well, they're correlated. I mean, I think emotion regulation is strongly underlying anxiety also. And we've had kids in our trial who are super anxious. Like the one story I skipped over was a girl who, 16-year-old female with severe anxiety. Like we had to apply for an IRB exemption because we skipped the IQ test, which was part of our inclusion criteria because she simply couldn't do it. Like anything that was had a possible right or wrong answer, she just froze and literally stopped talking. Very bright. I mean, this is a very bright verbal girl. And she is probably one of my, I mean, I put her in my talks because I think she's one of our best examples. Like, her mom wrote a book about being a mom of a teenage girl with autism. It included a story about her coming home and saying, Mom, I did something so exciting today. I raised my hand in class and I asked a question, and then she was like, that's great. And then she said something else really exciting happened. I raised my hand to answer when he wanted someone to give an answer, and I got it wrong. And her mom was confused at first, and then and it was like, wait, I'm confused. Why is that exciting? And she said, Mom, I got it wrong, and I didn't start thinking horrible things about myself or freak out. So, I mean, it was like a really big change for her. And I feel like what we were targeting was emotion regulation. So I think, you know.
Well, I think we have the last comment, which is just a big thank you. More requests for training on ease, which sounds like it's in progress, but not disseminated yet, right?
Yeah.
Okay. Anyway, I think we've kept you long enough, Carla. You got to go find out what your puppy is doing. And thank you very, very much for a really stimulating and enlightening talk. And many of us at UCLA will see you later. So thank you. Thank you.
Thank you for having me.
Bye.
Bye.